Thanks everybody for tuning in here at about the noon hour, and we'll go ahead and begin on today's topic, which is related to GLP-1 RAs and muscle health. A bit about me. Yeah, my name's Ryan McGrath. I am an associate professor here at North Dakota State University in the Department of Health, Nutrition, and Exercise Sciences. But I also have an appointment with the University of North Dakota, specifically the Department of Geriatrics in the School of Medicine and Health Sciences. Topics with respect to research agenda are wide-ranging, really dedicated on aging and health, but would probably describe it primarily as maybe prevention and treatment of age-related diseases and functional limitations that are connected to the musculoskeletal and neuromuscular systems. My background is in exercise science, so I just want to note that I'm not a prescribing physician, prescribing healthcare provider, nor am I a pharmacist. So keep that in mind that my background is primarily in exercise science and musculoskeletal health. And today, put together a series of objectives that I'm hoping that we can achieve with today's presentation, and I'll just kind of list these one by one. But first, present how musculoskeletal health could be screened and monitored for persons that are taking a GLP-1 RA. Maybe describe some challenges, some barriers that may exist for achieving the physical activity guidelines. And overall promote musculoskeletal health awareness for persons that are taking a GLP-1 RA or maybe healthcare providers that are working with persons that are taking a GLP-1 RA. So the older adult demographic in the United States is rapidly increasing. Specifically, some evidence suggests that Americans aged at least 65 years are projected to increase from maybe 58 million in 2022 to about 82 million in 2050, which represents an approximate 42% increase. The infographic on the left shares compatible statistics in that for the first time in the history of the United States, that older adults are projected to outnumber children by the year 2024. And we kind of see that crossover that may exist with youth and older adults. And with this population demographic increase and change, really, I think, presents other types of changes that need awareness. That could mean changes in housing. That could mean changes in healthcare. That may include changes in healthcare personnel. And all that included is also inclusive of maybe topics related to physical activity and health. The image that you see on the right side is an image that's generated by the American College of Sports Medicine, which tends to be the largest governing organization in sports medicine, exercise science, and related. And just speaking a little bit more anecdotally, year by year, I do see trends and changes in those trends. Wearable technologies tends to be the number one or near number one, and I recall has been that way for years now. But one thing that did catch my attention is number two, and that's fitness programs for older adults. And I think that this speaks to the recognition and maybe the changes in the population demographics and the importance of physical activity and health for older adults. Just some terminology to get ourselves acquainted with maybe some items that might be conducive to understanding physical activity recommendations. So physical activity specifically might be explained as any body movement produced by the musculoskeletal system or neuromuscular system resulting in energy expenditure. Exercise, physical activity can sometimes be used interchangeably in conversation. For example, I may describe exercise as maybe being a little bit more planned and structured. Physical activity can be planned and structured, but according to this definition may differ slightly. Sedentary behavior, for example, might be described as any waking behavior with a low energy expenditure. Behaviors may include maybe sitting in a chair, lying down, for example, during waking time. And then similarly to being physically active, inactive would represent maybe not achieving the physical activity guidelines. And it's one important note is it's possible to be sedentary, but still achieve physical activity guidelines. But the longer the sedentary behavior, the higher levels of sedentary behavior, there's probably going to be a relationship of sort with being physically inactive. And there are physical activity and nutrition guidelines that do exist. There can be differences in guidelines depending on the guidelines that are followed. But here are some examples of just overall guidelines. Some dietary guidelines that might be connected to maybe fruit and vegetable intake may include adults being recommended to consume maybe 1.5 to 2 cup equivalents of fruits and maybe 2 to 3 cup equivalents of vegetables daily. Whereas maybe physical activity guidelines might be more specific to type of physical activity. So aerobic activity, which may include 150 minutes of moderate to vigorous physical activity per week. With respect to muscle strengthening physical activities, muscle strengthening exercise of the major muscle groups for maybe at least 2 days a week. And when we kind of, I think, take a little bit of a look as to maybe the proportion of persons that are achieving maybe dietary recommendations, maybe in the ballpark of about between 10 and 15% with respect to vegetable and fruit intake. When eyeballing maybe persons that are achieving the physical activity guidelines, specifically the aerobic and the muscle strengthening activities, roughly 46% maybe not achieving either of those recommendations. More specifically, looking at maybe muscle strengthening activities only, a low proportion, less than 10%. And we see some differences in persons that are achieving physical activity recommendations, maybe based on age group, for example. And that's kind of what the diagram on the right helps to represent, is when we kind of look to examine maybe differences that might be occurring by age group, we'll note that persons that are aged at least 65 years, a low proportion of persons are achieving the physical activity guidelines. And there can be many reasons as to why maybe individuals across the lifespan may not be achieving physical activity guidelines. For example, maybe there's some limitations on social support. Social support can be differentially defined. This could be maybe virtual supports. This can be in-person supports. This can be other. There can be motivational factors connected to social supports too, with respect to relatedness, autonomy, understanding as to how to engage in physical activities, competence to engage in physical activity, which may also be included as pillars with respect to self-determination theory. Perhaps maybe physical activity could be viewed as elevating the risk for injury. There could be some costs associated with physical activity too, depending on if physical activity may include use of maybe a wellness center, for example. And sometimes those wellness centers aren't necessarily always accessible. And speaking a little bit about just me, for example, depending on maybe where you have a residence, weather certainly is a factor with respect to maybe participation in physical activity. I find myself doing different things maybe in summer months relative to winter months. There can be some challenges maybe with respect to weather, but these might be some examples as to maybe some barriers that may exist. These barriers may change across the lifespan. These barriers may be different from younger adulthood into middle age into older adulthood. But it's important to note that there are barriers that could be highlighted, and such barriers may limit a person's ability to achieve physical activity guidelines for Americans. Dietary guidelines, physical activity guidelines may have some relationships with a variety of maybe chronic cardiometabolic outcomes, maybe functional limitations, other health conditions. This figure specifically presents maybe the prevalence of obesity. We kind of oftentimes hear the role of physical activity and nutrition intake, and its important role for the prevention and treatment of obesity. But kind of some recent statistics would suggest that maybe 40% of American adults might be living with obesity, and obesity being defined as greater than or equal to 30 kilograms per meter squared with respect to body mass index. And we see some differences that might be existing across age demographics too, similar to maybe what we observed with differences across age demographics for achieving physical activity guidelines for Americans. Here we maybe see some differences with respect to the proportion of persons that might be living with obesity. Given that maybe physical activity participation and nutrition recommendation achievement may not be necessarily as high as maybe desired. There can be some opportunities maybe that have emerged recently with maybe other options. Here is some examples. So maybe while GLP-1, GLP-1R, and GLP-1RA could possibly be used interchangeably in conversation, they may refer to maybe three different types of entities, such as a hormone or receptor in a class of medications. So, for example, GLP-1Rs could be characterized as maybe a cellular receptor that's expressed in the cells in several tissues and organs. GLP-1Rs could be thought as of a specific lock, perhaps. And for a GLP-1 or a medication to have its effect, it fits into this lock and activates the lock. When the lock is maybe triggered, the receptor maybe initiates downstream signals that may lower blood sugar and slow gastric emptying. GLP-1 may be described as a naturally occurring hormone produced by the cells in response to food intake. Maybe GLP-1, for example, may help to regulate blood glucose and metabolism and appetite. It may support the release of insulin and slow gastric emptying, maybe signals to the brain, the promotion of fullness and reduced food intake. Natural GLP-1, however, could be limited by the breakdown of an enzyme activity that may last for minutes, representing a short half-life. And then where GLP-1RAs may factor in is a classification of medications designed to activate GLP-1Rs. And this class of medications somewhat act like keys that activate the same receptor that's targeted by natural GLP-1. However, unlike natural GLP-1, they could be structurally changed to be resistant to breakdown within the body. That could be lasting for perhaps several hours. GLP-1s are oftentimes prescribed for maybe type 2 diabetes or obesity, and they do come with maybe some notable adverse effects or side effects. For example, this may include GI factors, nausea, and sometimes these adverse effects may lead to discontinuation, which, for example, could be at the rate of about 10%. But nonetheless, they can promote weight loss. And the figure on the bottom of the slide helps to illustrate the growth and timescale of medical research on GLP-1, GLP-1RA, and related clinical trials. Notably dating back to the 1980s, where glucagon-like sequence was first identified in fish, according to this figure, and then into the 2000s when clinical trials and FDA approvals emerged. As time continued overall, publications and clinical trials on this topic have generally increased, as well as maybe our visibility on this topic with respect to the popular press. Online prescribing of GLP-1RAs is also present. In this secret shopper investigation, online GLP-1 prescription vendors may not often require clinical interaction, relying primarily on patient-reported questionnaires that may not capture important factors. Table 1 on this slide shows prescription process characteristic websites for selling online GLP-1RAs, while Table 2 presents characteristics of GLP-1RAs prescribed by online GLP-1RA sellers. Just for example, in Table 1, the article suggests that while about 80% asked about weight loss goals, approximately 65% asked about prior non-pharmacological weight loss attempts, and just over 50% asked about diet and physical activity. This investigation overall generally aimed to evaluate the proportion of GLP-1RAs prescribed, stratified by diabetes and obesity status to uncover trends using a retrospective population-based observational design. Table 1, which is located a little bit higher on the slide, notes that from 2018 to 2023, the proportion of persons with diabetes taking a GLP-1RA decreased from 89% to 66% respectively. Moreover, the proportion of persons in group 3, which in this case may represent no diabetes status, but not living with obesity or overweight status. Here, this group increased from 4.5% in 2018 to 17% in 2023. And similar trends were observed in group number 4, wherein maybe no diabetes status was present, but overweight and obesity status may have been present. And it's kind of interesting to see changes in these proportions over time, how they may differ across maybe diabetes status and similarly to obesity and overweight status, and noticing how that may have aligned with maybe some of the figures that we observed on previous slides. In the same study that generally overall aimed to evaluate the proportion of GLP-1 RAs prescribed stratified by diabetes and obesity status, and to uncover relevant trends using retrospective population-based observational study designs. Here, Table 2 outlines some demographic differences between all 4 study groups, and again, paying close attention to maybe diabetes and obesity status. So for groups 3 and 4, about 40% of persons taking a GLP-1 RA were younger than 45 years, and this was dissimilar from maybe the 2 groups that included persons with diabetes, groups 1 and 2, in which users younger than 45 years made about 12 to 18% of groups 1 and 2 respectively. GLP-1 RA users without diabetes were primarily female, while groups 1 and 2 showed proportions that were somewhat similar when examining the role of sex. So GLP-1 RAs have shown promise for reducing body weight and mass, and have kind of, I think, increased in usage. There are several statistics that exist that demonstrate its increase in use for many reasons. Probably have been seen also just anecdotally and in conversation, maybe changes with respect to the rapid increase in GLP-1 use, and sometimes age groups and different demographics may differ. So for example, the figure listed here may be somewhat compatible with maybe previous figures that we observed when examining the proportion of persons that might be taking a GLP-1 RA when considering the role of age group, in this case, looking at diagnosed diabetes for persons that might be using GLP-1 RA injectables. But nonetheless, there are risks that might be present. I spoke briefly about some of the adverse or maybe that perhaps side effects that might be present when taking a GLP-1 RA medication. I commented maybe more so maybe being GI focused, but there may also be some connections with musculoskeletal health and the rapid reduction in weight loss and how that might be linked to maybe losses in, for example, lean body mass. And sometimes, depending on the losses, the proportion of losses up to 40% of overall weight loss can sometimes be attributed to maybe a lean body mass, and such that persons that may have larger mass as a whole may have greater proportions of losses. And there can be some possible explanations for maybe why we're observing losses in lean body mass alongside just overall losses in weight. Some of these reasons may include that weight loss may include some lean tissue because intervention induced weight loss that could be significant and substantial, while often including fat, can oftentimes include maybe water and lean tissues, or maybe reduced energy intake and protein intake, and how that might be less when experiencing rapid weight loss may lead to maybe lower protein synthesis as a whole. Maybe lower anabolic stimulation from eating might be occurring, and maybe mechanical loading with respect to the musculoskeletal system may decline as body weight similarly lowers. And there can be some differences with maybe adaptive versus maladaptive responses to the musculoskeletal system when experiencing rapid reductions in weight loss. Adaptive muscle response, which might be with respect to intentional weight loss, includes body adaptation and being able to, I think, have energy availability, physical activity, and diet factors. Whereas maybe these factors become maladaptive when protein intake and resistance training may not be present. Older age and perhaps baseline sarcopenia, which might be a condition wherein muscle mass might be particularly lower, may also be risk factors for the role of GLP-1 RAs on muscle health. And maybe a little bit more conceptually too, GLP-1 RAs may lead to lower appetite and food intake, which may impact energy and protein, influencing weight loss and to some extent lean tissue. There are different types of GLP-1 RAs that exist, as well as other methods of weight loss. One study evaluated the disproportionate reporting of muscle atrophy in association with GLP-1 RA therapy using FDA adverse event reporting systems from October 2003 to March 2004. And the results suggested that semaglutide had 2.39 increased odds for maybe adverse outcomes related to atrophy, whereas tirzepatide had 1.69 increased reporting odds, indicating that increased reporting of muscle atrophy relative to other drugs that are included in the FA-ERS. However, these findings should not be necessarily interpreted as causal. It's more so as signal detection and really underscore the need for future studies incorporating objective measures of muscle mass and function. Figure 1, which is located on the bottom here, which is from a separate study, shows that a relationship of the percent weight loss to percent loss of lean body mass resulting in dietary intervention, therapy with GLP-1 RAs or bariatric surgery, and at the 10% threshold of body weight loss, diet had the lowest proportion of loss in lean body mass, followed by bariatric surgery and then GLP-1 RAs with respect to each of these three trajectories. Altogether, muscle loss during GLP-1 RA therapy is multifactorial, involving reduced protein intake, negative energy balance, maybe some hormonal adaptations, maybe factors related to mTOR signaling and a regular cell growth, metabolism, protein synthesis, and related, and its relationships to maybe age, frailty, and physical activity as modifiers. So this concept model, for example, proposes principal mechanisms for muscle loss associated with GLP-1 RA treatment and strategies. And in brief, physical activity may support protein synthesis, protein and energy intake may support muscle health, anabolic hormones and signaling may support muscle maintenance, and other factors may reduce muscle breakdown and stimulate appetite. So the health aspects of physical activity and the prevention and treatment of maybe age-related disease and limitations of the musculoskeletal system are certainly important during aging. And making note of this in the role of muscle health when taking a GLP-1 should be underscored. Thinking a bit about the role of atrophy, sarcopenia, sarcopenic obesity, certainly could be present and certainly could be considerations for persons that might be taking a GLP-1 or considering taking a GLP-1. If a person might be living with sarcopenia, for example, that may include already identified low muscle mass. So taking a GLP-1 RA could be met with caution because this may exacerbate maybe the sarcopenic condition, which may elevate risk for maybe falls, functional limitations, and other related factors. And also speaking to the role of maybe nutritional intake, malnourishment, looking at maybe the ecological approach to energy intake. There can be some biological factors, there can be some environmental factors that come together. So certainly important to consider the role of nourishment too, when considering taking a GLP-1 RA. And it could be notable that age is certainly a risk factor for the role of muscle mass and strength. There is some evidence to suggest that maybe factors related to muscle function, strength, and mass specifically may plateau in about 30s, and then kind of maybe decline into the 40s and then decline at a greater rate during the aging process. And it could be important to maintain muscle mass and strength during the aging process for many reasons. There can be some chronic disease factors that would help to prevent maybe some age-related health conditions that might be chronic or cardiometabolic. Also thinking a little bit about the role of basic self-care, daily living, functional preservations, being able to withstand stressors, for example, that might be acute or chronic. And certainly muscle mass and strength is important in that regard. when we see kind of, I think, some of these changes that might be occurring across the lifespan with respect to muscle mass and strength, we start thinking a little about the role of maybe lifestyle behaviors and how that may influence strength and mass trajectories across the lifespan. There can be on the image on the right an example of maybe a person that might be engaging in several healthy lifestyle behaviors, highly physically active, maybe a high protein intake. As such, peak muscle mass and strength maybe in the 30s is achieved and then is able to be preserved across the lifespan, thereby lowering risk for maybe a poor health outcome, which might be, for example, a functional limitation. Whereas another person that may not be engaging in healthy lifestyle behaviors, for example, may not be able to achieve peak muscle mass and strength. And then as a result, during the aging process, peak muscle mass and strength or just strength may change in general, thereby exacerbating maybe time to a functional limitation, maybe in middle-aged or older adult. The image that you see on the left is, I think, reflected, and these are percentiles that are related to maybe strength in a convenient and reliable way to examine strength across the lifespan. And it's kind of important to note that there can be some differences that may exist, looking at maybe the 95th percentile versus the 5th percentile, and some differences in strength that might be achieved and how they might be compatible with some of the curves that we're observing on the right. So speaking a little bit to the role of muscle mass and strength when taking a GLP-1 RA, screening for musculoskeletal health can be important. And one of those important musculoskeletal health conditions could be described as sarcopenia. The image that you see here is somewhat of an algorithm to help to determine the presence or absence of sarcopenia. And these are oftentimes assessed with 3 overall clinically feasible assessments. First, hand grip strength is a convenient and reliable measure of overall muscle strength to assess. Maybe if you want to confirm, maybe we would examine muscle mass. And then if we want to consider the severity of sarcopenia, we could engage in maybe some physical performance tasks, which may include gait speed. Speaking to maybe the different layers of tools and methods that may exist with sarcopenia screening in clinical settings, just overall, or for perhaps persons that are taking a GLP-1 RA, hand grip strength. The image listed here is a hydraulic hand grip dynamometer. They are readily available oftentimes for purchase. I want to say that they might be available even on Amazon for purchase. Overall easy to explain, overall easy to administer, simply encouraging individuals to squeeze the dynamometer with maximal effort, exhaling while squeezing and then releasing, maybe completing this task 2 to 3 times on each hand, alternating between hands. This is also maybe connected to the geriatric 5Ms for age-friendly clinics. Oftentimes maybe we think a bit about mobility as maybe gait speed or other multi-joint tasks that might be lower extremity focused, but similarly too, strength capacity can be connected to mobility, and it oftentimes represents maybe the first step in the functional decline process, such that muscle function and muscle strength are oftentimes connected. And represents the onset or the early phases of maybe the functional decline process that may occur during aging and comes oftentimes before maybe mobility related tasks such as gait speed. So this enables us to have early intervention, which may have benefit. And a little bit more about hand grip strength too. Regarded as a convenient, reliable assessment of overall strength capacity. Overall, individuals understand muscle strength. There's a pretty good understanding as to maybe what muscle strength is. It can be done privately, it can be done in a rooming process, generally pretty inclusive of functional abilities, enables maybe clinical conversations to engage with respect to the role of physical activity and nutrition for helping to preserve muscle health across the lifespan, including for persons that might be taking a GLP-1 RA. And it's well used in the scientific literature. There's percentiles that exist for helping to make peer comparisons, perhaps with hand grip strength being at the 50th percentile versus the 35th percentile. And then similarly too, there also can be cut points that exist for helping to define clinically relevant weakness. Those cut points, for example, may include less than 26 kilograms of grip force for males and less than 16 kilograms of grip force for females. Just as maybe an example protocol that does exist, there tends to be somewhat of heterogeneity in hand grip strength protocols that are oftentimes utilized, but this is just an example as to if you are interested in collecting hand grip strength for musculoskeletal health in a clinical setting, this might be just a very brief overview as to how to collect that information. Oftentimes seated, maybe with sitting on a chair that has backrests and arm rests, and then resting the arms on those rests with hands in a neutral position and feet flat on the floor. You could explain the hand grip strength procedure and demonstrate. Oftentimes, when I hand the hand grip dynamometer to a person that has not completed the test before, there's a little bit of surprise that the dynamometer doesn't move. It's something called an isometric contraction. So it's kind of like a static movement, although force is being applied to the dynamometer. It is adjustable, so when thinking a bit about comfort and hand size and how that may be influential into grip force, oftentimes the dynamometers are adjustable to the hand size, and trying to identify the good, comfortable positioning for the participant is good before executing any testing. And then asking participants to squeeze with maximal effort, exhaling while squeezing for maybe a couple of seconds and then releasing, recording the measures, alternating between hands, 2 to 3 trials on each hand when possible. And we oftentimes include the highest recorded measurement of those multiple measures as just overall muscle strength. Looking at the next layer, there can be some opportunities to engage in muscle mass assessments. There are also a variety of tools that may exist for engaging in muscle mass assessments, some of which may be a little bit more instantaneous and clinically feasible, whereas others may include maybe a follow-up or a referral as appropriate. But strength and mass, although related, could be uniquely different attributes of musculoskeletal health. But nonetheless, maybe when examining the role of musculoskeletal health and sarcopenia, muscle mass is definitely something important to consider and may represent the next level on the algorithm that was presented earlier. And then also too, looking at the severity of sarcopenia and taking it a step further. Here's where maybe we see the physical performance tasks with respect to maybe the mobility tasks that we're oftentimes identifying maybe in the geriatric 5Ms that may include gait speed, maybe other attributes such as chair stands and tug, and kind of, I think, connecting to as to how this may influence maybe fall risk, may how this influence activities of daily living. These are unpublished data, very preliminary data from work that was recently completed at a community pharmacy in older adults that are taking a GLP-1 RA, and just kind of looking at their overview as to their level of concern with muscle and bone health. And those are the first 2 rows on this diagram on a 10-point Likert scale, and somewhere in the middle, not high level of concern, not a low level of concern, so just overall neutral. But one consistent, I think, theme that we've seen with respect to these preliminary data is maybe there's not always a conversation with the prescribing healthcare provider about muscle and bone health when taking a GLP-1 RA. Maybe assessments of muscle and bone health may not necessarily be occurring when visiting a prescribing healthcare provider. So larger proportions of adults that are taking a GLP-1 RA, older adults specifically, are reporting never having conversations with maybe muscle disease, bone disease, or assessment of musculoskeletal characteristics such as those that I described earlier, which may include hand grip strength, muscle mass, and physical performance. So overall, considering the possible importance of physical activity and nutrition for a person that might be taking a GLP-1 RA for musculoskeletal health, it should be underscored, and there should be some awareness to the importance of physical activity and nutrition intake for persons that might be utilizing these factors, and just kind of have some awareness to maybe a person that might be taking a GLP-1 RA and their journey that may have included maybe physical activity participation, nutritional factors, maybe thinking a little bit about something called the trans-theoretical model, and their interest and level of engaging in physical activity with respect to maybe exercise behavior or nutrition should be considered. but also just maybe have some awareness for the short and long-term health implications, specifically for muscle health. When we think a bit about age-related changes to the musculoskeletal system, maybe when taking GLP-1 RAs, depending on a variety of factors, this may exacerbate maybe problems related to musculoskeletal health in some cases. Um, Important to have conversations, important to maybe have assessments when appropriate in clinical settings, and having conversations with other individuals is crucial. But there also, in the same line, could be some consideration for prescribing, which may include maybe the weighing of the risk versus the weighing of the benefits for each individual case. But nonetheless, consideration for the role of musculoskeletal health in the short and long term should be considered as appropriate. We'll move into the presented case report here. And in this case report, maybe we have a 59-year-old male that might be living with type 2 diabetes and is reported as engaging in a sedentary lifestyle. For therapy, maybe they started their GLP-1 RA about 6 months ago for weight management and glycemic related controls. Why this matters: rapid reduction, maybe in 35% pounds, 35 pounds, but maybe notes that there could be challenges from getting up and down from a chair, self-reported fatigue, or feeling of frailty. Notable assessments maybe include reductions in body weight, lean body mass, maybe perhaps looking at hand grip strength as a factor for this particular case report.